Good afternoon. Welcome to Blanchard Valley Health Systems Live and Learn. I'm Bill Coates, an administration and internist here in the hospital, and we're going to talk about pain today. Before we get started, a couple of things to remember. If you have questions, just type them in. We're not going to have any live questions, but we do want to hear from you as to what your thoughts would be, questions as we talk to our speaker here this afternoon. And also at the end, there's going to be an evaluation. We try to make decisions as to how interesting this is to the community. We're out there to educate in these programs. So we give you the opportunity to give us some feedback as if you learn things or if you have other topics that you think that we ought to present. This has really worked out in the past well, that I think we've been able to give a lot of really good information to our community. So my guest today is my friend, Thomas Kendall, who is a pain management doctor. And I thought maybe we'd start by, Tom, just tell us a little bit about yourself. How'd you get into taking care of pain, which could be, I'd say, kind of a tough problem sometimes. You're at the end of when people are having difficulty. So how'd you get interested in this?
That's a good question. I was a chiropractor. That was back in the late 1990s. And I felt like as a specialty, it was quite effective. I also felt there's a little bit more I could offer. And that's what led me on my pursuit to obviously go to medical school and then eventually get into an anesthesiology residency, which I completed at the University of Toledo, with the idea the entire time essentially to get into the pain world. And most of the pain specialists in today's environment have their background in anesthesiology. I did complete a pain fellowship, as most people in pain management do. That was at the University of Michigan. And then naturally, I had a conversation with one of the doctors here, Dr. Ned, who was very helpful and instrumental in getting me here back in 2007. And I've been here since.
Yeah, you've been here quite a while. So why would anesthesiologists be the one? Because of learning procedures, or why? And do you have to be going through anesthesiologist to be a pain management doctor?
You do not have to be an anesthesiologist to go into become a certified pain management specialist. There's a couple paths that you can take. Anesthesia probably constitutes about 80% of those folks, I would imagine. The remainder would be neurologists, physical medicine and rehabilitation specialists, some psychiatrists, believe it or not. And I think what that speaks to is the wide array of issues that someone suffering with chronic pain has to deal with. It's not just a physical problem. These types of issues can consume a good portion of your existence, and there can be social aspects, psychological aspects to a chronic pain problem, and that may be reflected in some of the subspecialties or specialties that go into pain. In terms of why anesthesia was kind of the ones who were the majority of the people in pain, a lot of what anesthesiologists do is control pain, both intraoperatively as well as postoperatively. And they use techniques like epidurals and, various blocks of sorts, obviously medications, intravenous while you're in the hospital, mind you. And so it's just kind of natural outflow of our world in the postoperative and intraoperative acute pain management that we became kind of the majority in terms of who goes into the chronic pain world.
So you've had a lot of education, chiropractor, medical school took a while, then an anesthesia fellowship. And how long does it take to become board certified in pain management? Is that another couple of years?
The board certification in pain management, as I suggested, it's a year-long fellowship course.
Okay.
Prior to that, you would have to do, to my knowledge, a full residency, and that can range from 3 years in anesthesiology to maybe more in neurology. I'm not sure what their requirements are. And there was an internship year as well prior to that. So in addition to that 5-year commitment, you have to do the 4 years of medical school.
So I think we've substantiated we have an expert, along with a lot of experience of seeing a lot of people. I know a lot of the things that they see over in your practice. So where is your practice? Where all do you see patients?
At Blanchard Valley Hospital in the Roos Center on the 3rd floor. So my team is made up of Dr. Gydritis, who joined us actually a year ago yesterday, and we're glad to have him. He's doing a wonderful job as our colleague. Our team is comprised of many nurses. We have 2 nurse practitioners, in our clinic, and we do a lot of work, as you can probably imagine. We do have a group down in Bluffton as well. So some of our colleagues are down in Bluffton. They service more the Lima area. They don't really mix with us here in Findlay on a regular basis. But as you can kind of get, it's a big group. There's a lot of chronic pain out there. It's something that takes a lot of understanding and empathy, and takes big teams of understanding people to really manage those types of issues.
So while we're talking about your practice, and we'll get into this a little bit, does someone have to be referred to be seen? Is this a direct call someone can make if they have a concern, they want to get their own second opinion? Is that insurance driven, or how do you try to handle those things in your practice?
Well, we try to handle them to make it user friendly, so patient friendly, because the chronic pain patient is sometimes overwhelmed or frustrated with their pain condition. To that end, a referral at this point is not mandatory from the perspective of our department. Now, the caveat there is some insurers may require a referral to a pain specialist. Workman's compensation, for example, is one, and there may be others I'm not aware of. So the access is pretty much if you can get a hold of us, which you can through the hospital, even the hospital operator, quite frankly, we can get you involved in pain management. Now, part and parcel of that is having the recognition that we work with a team. So pain is not an entity. We don't work on an island. Of course, we work with various providers from various specialties. One important facet of that is having a primary care provider. As you can imagine, there's a lot of causes of pain, and some of those are medically driven issues. And and what I mean by that is, it could be an infection or a tumor, God forbid, something along those lines. And you can imagine where having a primary care provider is critical to help medically co-manage the pain syndrome that we would have found, for example, on an image or a test, for example. And so to that end, we do have service available here at the hospital, and primary care services available here at the hospital. And so, for example, if we found someone who was referred to pain management and didn't have a primary care provider, one thing we might consider is to make a referral to one of our colleagues here in the Blanchard Valley system. And the reason is, as I suggested, it's critical that you have that. So that's where we are on getting to us.
Well, obviously, we're talking about pain today, and we primarily want to talk about chronic pains and what we can do. But maybe a higher level, why do we have pain? Why does our body give us pain? And you want to talk about maybe some of the acute things that you see before we get to chronic. My preference is if I had an acute pain, I'd rather have it taken care of so I don't get a chronic pain. Any just high-level comments along those lines?
Yes. And so most of us are aware that pain is just an untoward or a very unpleasant reaction. It's the body's attempt to tell you, stop doing whatever you're doing. I mean, the obvious examples, if you reach over a hot stove and then your pain receptors are stimulated, you pull out. And why do you do that? Well, you don't want to destroy the tissues in your arm with a burn, obviously. And that's easy to understand, quite frankly. A broken leg, whatever it may be, those issues are fairly evident. Chronic pain is where things get a little blurry from the perception of, there's really not a test that I'm aware of, or blood work or an MRI or an X-ray that can show chronic pain. And so the challenge that the patient would have, quite frankly, is really demonstrating to others that they have pain when, they're walking around, they don't see any blood, there's nothing lacerated, there's nothing broken, but yet they hurt. And the blood work and the X-rays sometimes don't always show that. And that's where chronic pain is different from an acute pain issue. And that's our challenge as chronic pain providers, is to understand that, obviously, and then be very empathetic to the fact that, these people are sometimes poorly understood. It's our job to try to understand them and give them an avenue by which to express themselves. And so we can empathetically understand what the issues are, make a diagnosis, and then find some treatment for it. Briefly, when we cross the 3-month threshold, this is a very generic definition of when pain becomes chronic. And so we see a wide array of things in our clinic, as you can probably imagine. There are some acute people that have acute problems that need treatments that we have to offer to quiet those things down so they don't become chronic, as you alluded to. The issues with chronic pain can really become overwhelming. And obviously you can have a low back problem or a headache that hurts you, but it probably wouldn't take much to imagine if you had that every day and you missed work and you couldn't go to your kids' baseball games and you couldn't sleep very well and you couldn't exercise. I think it's pretty easy to demonstrate how this could really snowball into a problem that could affect you in a really, really big way, not only physically, but certainly emotionally, socially, and it could really have far reaches.
So what kinds of things do you see in the office? What, if you put it into different kinds of categories, what things are you referred, people call in about, percentages, or just kind of give us an idea of what you're seeing? And I'm sure we're going to be talking about lower back. There were a lot of questions that came in about that, but what other kinds of things do you see?
Lower back and neck probably comprise about 80% of what is referred to us in the clinic. As a caveat to that, the spine's a pretty potent or pretty powerful area of the body. Obviously, the arms and legs are connected to it, and sometimes we find things that aren't always recognized, and some of the neck pain syndromes can lead to headaches, dizziness, arms and legs being heavy and clumsy, and sometimes you have these issues without pain. And so we recognize the neck in particular and the cervical spinal cord as a fairly integral organ in things like balance and so forth. And sometimes those things crop up or become apparent to us after our examinations. And so we find those types of things maybe incidentally when they're referred for a lower back pain problem, for example. In addition to the spinal pain problems, we do manage headache syndromes, a couple of kinds. There's the headache kind of in the back of the head that tends to have a neck or tension focus to it. There is treatment for migraine headaches, and then the FDA has a protocol for that includes botulism toxin filtration, which is a very specific, well-studied scientific approach. It's done down to the unit of Botox, so it's very concise and quite frankly very helpful for people. It's not uncommon for us to deal with extremity pain syndrome. So after sometimes very innocuous or benign injuries to the hand, wrist, ankle, or leg, the pain persists. It's a very unusual situation. I would imagine the patient would feel a sense of just wonderment or alienation because your leg hurts after you've had a sprained ankle. We deal with issues like that. And this is truly the essence of chronic pain. Postherpetic neuralgia, trigeminal neuralgia, which is where the face hurts, are very, very serious conditions that cause people a lot of discord and a lot of agony, quite frankly. And so those are some of the kinds of things that we deal with.
So you mentioned postherpetic. For all of our audience, that would be someone with shingles, and I used to deal with a lot of that. What's your modalities? What can you do besides me giving you some kind of a narcotic or pain medication to take care of? I think that's one of the concerns anymore. We'll talk more about that, of what medications we can use, but what are you able to do with shingles?
One of the first things that you would learn in a pain management fellowship would be that nerve pain. And you can probably imagine where post-shingles pain is a nerve pain syndrome. And it's typically described as a very sharp, lancinating, lightning bolt type sensation. Of note, that is very poorly responsive to the opioid analgesics. And what I mean by that is the painkillers like tramadol or codeine or morphine or Vicodin. And so you could be in a situation where you're taking quite a robust dose of that medication because it hurts badly, and you're not going to find yourself responding very well. So you'd end up having side effects from the opioid painkillers, the Percocet or the Vicodin, poorly controlled pain. And this speaks to kind of the underpinnings of a nerve pain problem. To answer your question more directly, there are medications that we use specifically for nerve pain issues. And, most doctors are aware of those things. And an injection to that nerve, quite frankly, can be incredibly helpful and quiet your pain syndrome quite effectively.
So do you have to wait so long before you have that? I mean, if somebody had a bad case of shingles and it was really hurting, wait a couple of days, or is this something that you wait 2 or 3 months and see where things were? What do you see of what you could advise people that it would be most helpful for?
Well, I mean, you can treat the pain with an oral pain medication, while you're having an active lesion or an active rash, so to speak. When we say active rash, sometimes those tend to weep or cause a little bit of drainage, so to speak. You wouldn't want to go into the injection world until you had those that rash heal over or crust over, you wouldn't want to do an injection while you have an actively weeping lesion. But certainly the oral pain medications, if that's ineffective and the lesion has healed over, the rash has healed over, an injection is something that we do with regularity. And you want to consider doing that sooner rather than later, because as days become weeks and weeks become months and months become longer, you can imagine your life can really unravel from something as benign as shingles.
Yeah, in my experience, those were they were tough cases. That
They are
10% that you don't even see a rash, and trying to figure out what's the neuropathic kind of pain.
very tricky.
Well, before we go to back, you mentioned about headaches, and so with Botox, how long does a shot last? I'm now a layperson. I don't have any idea. Does it a couple shots take care of it, or is it a chronic kind of condition that you're going to treat, or everybody's different?
So migraine prophylaxis, for definition, so to use the Botox for migraines, you have to have a chronic syndrome. The insurance companies would essentially require that. The typical duration, or how long the Botox lasts, is about 2 to almost 3 months. There's a limit on the amount of Botox that one can be administered. So if you inject the Botox sooner than 3 months, you have the chance of developing kind of a reaction to the Botox. And so for that, to that end, again, I described this, the FDA Food and Drug Administration protocol allows you to do Botox, and this is based on safety and science, allows you to do Botox every 3 months in those well-described points in the head, face, and neck area. And people tolerate that very well and do very well with it. And again, I would say, 2.5 months is pretty average. And about the time they're ready for the next Botox is when the previous session wears off. And in terms of, completely getting rid of migraines, it can happen. Most people are in the category or the camp that, hey, listen, I've been suffering for these for years before they come to you. That's typical. If they get relief, coming in for a shot every 3 months is really a small price to pay for them.
For sure.
And unless things change, you'd continue that for the time being.
Yeah, migraines, the headaches, incapacitating as too.
Mm-hmm.
What's what in your experience? How effective is that? 80,
Just off the
90%?
cuff,
Yeah.
I would say between 80 and 90% of the people that get Botox again repeatedly. And this obviously speaks to the fact it's giving them some benefit.
Right. Okay. Well, here's a question that I think summarizes a lot of the others. That let's just start with it. We're going to be talking about lower back pain now, which is not only of a lot of interest. It's if you look at our economy, a lot of people are off work. You've mentioned workers' comp. Most of us have some backaches. And so we'll try to cover it from several different avenues. So the question is from Kimberly and Finley. How do I know when it might be time to try pain management to help alleviate my symptoms of advanced arthritis in my lower back? Currently, I manage my pain with stretching and exercise. Each year, my pain daily increases, especially when I wake up each morning. So, Tom, how would we approach this person?
Obviously, a great question, Kimberly. And I think that most people would be in tune with their function. When you can't do the things you want to do, when you can't exercise, when you can't do the laundry, when you can't go to your kids' or grandkids' baseball games, and you're skipping those events because of your back pain, I think that's a clear indication that something needs to be done. So from a functional perspective, that would be the guide to me that things have to change. A backache that lasts 3 or 4 days, we're not talking about that. But if 3 or 4 days turns into a couple of weeks, certainly it's time to do something. The other syndrome or other process that I think that we would see, and this has happened to me personally, is you have your backache when you're in your 30s. It's pretty bad. It can keep you down for a couple of days. But then when you get in your 40s, it happens a couple times every couple months, and that becomes a couple times a month. And so the frequency is increasing, I guess is what I'm getting at. And that would be another indication that these severe backache syndromes, when they're happening more frequently, would be another indication that it might be time to get an assessment. And I'll bring to your attention this. Pain is the body's way of telling you something is wrong. We discussed that with putting your hand over an open flame or your arm over an open flame. You can kind of imagine something like that occurring in your lower back. This is your body's way of saying there could be an injury down there. It's never inappropriate, in my humble opinion, to consult medical advice. and your physician can decide whether or not an X-ray or an MRI or something along those lines is warranted. And so again, I would take my body's pain as a serious indicator that something should be looked at.
So once that evaluation's done, and you've mentioned some of those things, I would assume, depending on what you find on physical examination and how old someone and how long it's lasted, let's assume that it is decided that it's advanced arthritis, whatever that means, and it doesn't look like a procedure, at least to start with, or that you need to see a surgeon. What kind of modalities then, and how do we interact with? There's a lot of people out there that are treating backs. When can somebody go to the Y? When can somebody go to start yoga? Or how do you advise me as to what I ought to do, depending upon what my symptoms, let's say, may be?
Okay, well, that was a big question.
Yeah. I'm an internist, remember. It takes a long time to get out of thought.
Got it. No, that's good. So to address a couple of those issues, I mean, at some point in time, always a physical examination and a history is really part of what we do. And without that, you're nowhere, obviously. Imaging is a very important tool for us, whether it be an X-ray or an MRI. And very briefly, an X-ray is of some usefulness. It shows what the bone structure looks like. What it doesn't show is what the disc and nerve structure look like. I would consider those as soft tissues. And that's where an MRI comes in handy. So most of what we do entails an advanced image, and an MRI would be an example of advanced image. CT gives us about 80% of the information from a pain management perspective, an MRI does. And so now we've gone to the point where we have some imaging of the lower back. And based on the imaging and your physical examination findings, we try to arrive at a diagnosis. The diagnosis in the back, and I've alluded to a couple of these things already, can range from a chronic arthritic pain problem, which sounds benign, but when it affects you every morning and it takes you an hour and a half to do something you could previously do in 10 minutes, I'm talking about brushing your teeth and making breakfast. That's the truth of it. That warrants treatment. The other category of what we commonly see in the back is a disc or a nerve problem. Sciatica is kind of a variant of that. Sciatica is pain that goes down the leg, and which can be accompanied by weakness. And so once we have the diagnosis kind of tuned in, we then describe therapies that would be appropriate. If I can back up a little bit, one of the caveats that we have to face on a regular basis is meeting criteria for an MRI. And so just because you hurt and just because we think we need an MRI, we have to be cognizant of the fact that many insurance companies require some conservative therapy prior to allowing us to get an MRI. And this is not a rule. There are instances where one can get an MRI without going through a conservative therapy, but this speaks to the fact that things like stretching, physical therapy, chiropractic, from a physical perspective, are generally thought to be appropriate prior to considering advanced imaging, and that's usually over a 6 to 8 week period. And that can be accompanied by the use, and should be accompanied by the use, quite frankly, of medications by mouth. And the classes that are very common would be the Tylenol class, which just kills pain. The anti-inflammatory medications, which have an anti-inflammatory component to them and can alleviate pain. And the caveat with the anti-inflammatory medications is these can have systemic effects, as you are well aware. That can affect renal function, that can affect acid production in your esophagus and stomach, to the point where it can diminish those or diminish the protective mechanisms against acid, and that can cause an adverse reaction. And then, so the careful and appropriate administration of NSAIDs is what we're talking about, and then muscle relaxers. So long story short, once we've gone through those conservative measures, which are important, key, and critical, if those fail to get us the relief we're looking for, then we go into the advanced imaging world.
So if you were to see me, you might say it would be fine to go see a chiropractor, which they would be independent. If you were going to send to physical therapy, they need, I believe, a written note from a physician recommending that they do that. But appropriately, after the diagnosis is made, then those modalities may be of help. I mentioned the Y or yoga or things like that. But that's after there's been some evaluation diagnostically as to what the problem is.
Yeah, correct. After we evaluate the patient,
right,
maybe got some X-rays, we would try the course of conservative therapy, as you alluded to, physical therapy, chiropractic or otherwise. and then reevaluate after that course of conservative therapy. And at that point, imaging might be a part of the picture.
Okay. And after then, let's just say after you've imaged, that you may see something that needs something else. What other kinds of things do you do in your practice as you get into more, let's say, more procedures?
Got it. And as you're alluding to, we do injection type processes in the spine. Those can range from steroid type procedures, which in brief is putting a steroid very close to a disc bulge or herniation, where it approximates the nerve that's being inflamed, and that can be quite effective in alleviating that. We can do procedures into the joints of the lower back, and this would be an arthritic pain problem, which is typically something that's, generally speaking, more severe in the morning. The arthritic pain problems typically don't go down the leg like a sciatic or disc problem would. And we have a fairly effective modality for that, both in the neck and lower back, that involves cauterizing or burning the nerve supply to those arthritic joints. And that can give some fairly sufficient and helpful long-term relief. So that's kind of what we briefly do from an interventional perspective. And these are injections that are done routinely under well-controlled situations. We use imaging or X-ray to help us, to assist us in putting these injections in the appropriate and safe place. They're done through very small needles that cause, very little discomfort. Sometimes we use an oral sedative to help people get through what can be an anxiety-provoking situation, more so than painful, and that's the truth. But in summary, what I'm suggesting is this can be done safely and in a well-controlled environment, which we do in the Roos Center in our pain facility.
Before we take a couple of questions, I just want to make sure we not so much pursue this, but in my experience, I think pain management has changed from when individuals may be referred or ought to be seen. And so when I say that, it used to be more, you saw the failed backs. They'd already had surgery. They had problems that surgery, let's say, didn't take care of, or something came back. You alluded at the beginning that taking care of pain is multifactorial and it's a team approach. So do you have any feel about that as to when people ought to see you? I know neurosurgery orthopedists refer to you, or you may see them first and say, no, this is a procedural thing that you're going to need surgery, and refer. How do you all work together? And what would you, again, advise people when they're being seen? Now, if they've seen their primary care physician, they're going to be making a decision also. But thoughts on that?
Yeah, I think generally speaking, most of the people in the spinal pain world would recognize the continuum that's out there. And essentially, we try and treat these back pain syndromes from a less to more invasive way. And so we would do, and whether you see the neurosurgeon or the chiropractor or the pain specialist first as a specialist, we would kind of get you in line to go through the less invasive or the least invasive processes first, the physical therapies, the oral medications, and then the continuum would take you to potentially a pain type evaluation and potentially an injection prior to consideration for back surgery. And that's fairly well established. And again, it doesn't matter who you see first. If the primary care doctor refers to one of those entities, that's probably the route that is most acceptable, usable, and customary.
Okay, thank you.
Yeah.
Have a question?
Yes, we have several that come in. Linda from Bluffton, Ohio, she's asked, concerning the types of medications you administer when doing a procedure, are they or can they become addictive?
The short answer is no. And to speak specifically to what we inject in or near the spine or discs or nerves, those would entail things like primarily a steroid type medication, perhaps a nerve pain medication, and some local anesthetic. Local anesthetic is what your dentist would put in your gum area to kind of dull the pain while they're doing their procedure. What we would not inject are things like morphine or hydrocodone or Percocet. And so while you can get addicted to anything, I mean, the potential for becoming addicted to what's injected in the spine, at least the way we handle it, is it's almost zero. It's approaching zero, mind you. Now, this doesn't speak to the fact that there are some very advanced pain syndromes whereby a specialist could put a morphine type infusing pump into your spine. That is not done with frequency. Actually, the reason for that is to prevent those medications from interacting with the brain receptors, which kind of where tolerance has its effect. So if you don't have the medication affecting your brain receptors and it only stays in your spine, so to speak, that would actually be a way to get some morphine into the spinal area without having tolerance be a huge issue or addiction, as you suggested. And so that's the one answer whereby it needs some qualification. And let me just quickly talk about tolerance, dependence, and addiction. These are big words nowadays. Tolerance it deserves to be defined as when a medication that you had been taking and gave you an effect doesn't do that anymore. So after a period of time, whether it's 2 days, 2 weeks, or 2 months, you just don't get the same effect that you had initially. That's tolerance. Everybody has that. That's normal. Dependence, an advanced concept. When you are taking a medication for a while, in certain instances, when you stop that medication abruptly, you will have withdrawal from that. And addiction is a third entity. And, we don't see addiction. We don't treat addiction in our clinic. We treat chronic pain. Some people obviously can have chronic pain and addiction, but that's a separate entity. I wouldn't blur those two. They're not the same thing. Addiction is essentially when you would use a chemical or a medication for purposes other than controlling pain, despite the fact you could harm yourself or others from its continued use. So that's an important designation.
One of the things that you mentioned, and we'll see if we have any more questions here in a second, how, if you do an injection, do you get instantaneous improvement? How long does it take? How many times would you, let's say, inject a steroid before this is not going to be effective, or we usually see some kind of response?
Good question. There are obviously limits on how many times we can do that, both from a practical standpoint as well as a safety standpoint. But there's a very important pain or patient driven component to this. And so, as a consumer at this point, so I'm sitting here going for my pain injection. If I find that I've had one and now I've had a second and I'm not getting the relief I'm looking for, your discussion with, or my discussion with my doctor would be, doctor, these aren't giving me the relief or functional improvement I was hoping for. And so we would consider changing course at that point.
So you would expect after a couple that you would have seen some marked improvement or some improvement if you were going to continue doing that, realizing you can't keep doing them forever anyhow because of the medication.
Well, we're talking about a chronic problem. So,
Yes.
I mean, if there was one shot you could have for your diabetes and you'd be good for the rest of your life, you would take that shot. And so it's a chronic issue. And so it may involve, multiple sessions of treatment, but you should get a prolonged response to the point where in the points that you are between your injection therapies, I mean, you should be able to improve your function, build your core strength and stamina, the point where you're doing things that you couldn't do previously. And so you should see marked prolonged improvement from one of these injections to make it, worthwhile, as it were.
So you would be doing, let's say, the injections along with maybe physical therapy or something else to be improving your core strength, et cetera. There may be multi things that are being done while you're treating.
Correct. And you can imagine where you want to get out and walk because you just feel like you're losing some of your aerobic capacity and you can't because of the pain. Right. Obviously, the idea behind the injection is to alleviate the pain to the point where you can participate in those aerobic as well as core strengthening activities. So it's mandatory that you do that if you want to really take full advantage of what these types of modalities have to offer.
Okay, thank you. Another question?
Sure. Carol from Bowling Green, she asks, are there any side effects or negative factors to consider when doing injections or procedures on patients with underlying conditions, such as high blood pressure, diabetes, or chronic kidney disease?
Those are all great questions. And, the side effect profile from the medications that we inject is fairly narrow and not very common. We use steroids. The most common effect that we see from the steroids or adverse reaction is an elevation of the blood sugar. And that's, fairly common knowledge to a diabetic. Outside of that, the medications themselves do not precipitate a wider range of adverse reactions. We even rarely see allergic reactions. And I would differentiate that between our adverse reactions of the medications to the complications that can happen when one puts something in the spine, speaking very generally. Anytime that's done, There's a chance for bleeding, infection, or nerve damage, and that would be a disastrous consequence that thankfully is extremely rare. It's not zero, but frankly, it's approaching zero. So it's certainly a much less than 1% chance that those types of things happen. And so that's what we're looking at from a complication as well as medication side effect profile.
Good. Other question?
Sure. Tom from Finley asks, considering patients with pre-existing conditions, do you recommend any special instructions for patients to follow before and after the procedures?
It's a pre-existing conditions is kind of a wide open thought process. People that are on dialysis, for example, or do have allergic reactions to some of the agents that we do inject, they would have to be pre-treated. Occasionally, we would ask for a cardiology, let's call it evaluation or optimization or clearance prior to some things that we do. In specific, some of the burning or some of the nerve cauterization stuff that I described to you does involve an electrical apparatus. And if you have a pacemaker, we have to take that into consideration. And in some rare cases where the pulmonary function is so poor, we would have the pulmonologist perhaps describe a regimen prior to the injection. All that's exceedingly rare, mind you. Outside of that, it's not a very invasive process. What we do, generally speaking, in our operating room from an injection standpoint, and so we can usually accommodate those issues without, as we don't affect the body systems to a great degree.
Yeah, I would reaffirm that. I don't know if you've seen anything, always worried about steroids, maybe affecting diabetes, but if you tell someone, and I don't know whether the injections do much of that, but anyone that has a chronic condition, heart, lung, that for what you do, that's not a problem. It's not.
And quite frankly, you might be able to imagine whereby the patient is scheduled for surgery, but they don't meet criteria for surgery. And that's a different, more invasive process that involves, more of a demand on the body systems, heart and lungs included. And where they don't meet criteria for surgery, this is where we come in. And the rationale is, well, these are minimally impacting the body systems. Right. And so the injections can be done where surgery can't in some cases.
Right.
Amy from Finley asks, what is a common assumption about chronic pain that may not be true?
That's a good question.
You want to repeat that?
Sure. What is a common assumption about chronic pain that may not be true?
I don't know how common it is, but I think it could be potentially deleterious to the chronic pain patient. I feel that the chronic pain patient doesn't feel that they're believed. And I mentioned this at the outset. When you don't have a test or a blood type or an MRI or a sheet of paper that clearly demonstrates what your pain diagnosis is, and pain is not visible on a diagnostic test that I'm aware of, it becomes difficult to demonstrate that to their peers. And so that misunderstanding is great, and it carries forward. When you don't see body parts that are broken, or you don't see lacerations that are bleeding, to say your wrist hurts when your wrist looks normal is a very bizarre concept to some people. It's a very real concept to us. And that's where a couple of things happen. It's our job to not only be empathetic and listen to the patients, obviously, it's our job to give them the sense that, what they're feeling is the correct feeling. And to recognize the fact that it affects them greatly. And the modalities that we have are designed to make small but incremental changes in their perception of pain and their function to improve those things. And then they can work with what they have to function and behave at a much higher level. And so just accepting their condition is, I guess, the big point. And then treating, as we alluded to a couple of times now, these chronic debilitating long-term conditions in the absence of any outward signs is certainly our challenge.
Yeah, I think not just to add on to that, would be a little different. I think that's a great answer, is people not being believed, and then it affects all types of your life. It's almost to the infrastructure of the problem that it's not appreciated. You don't get any sleep, you're depressed, and so people see another problem. Your family may see another problem, and the real difficulty is chronic, as you said, chronic pain can be just unstabilizing to your total body.
And then part B to that answer is, and we mentioned this earlier, is addiction. And for some reason, it seems like chronic pain and addiction can be used interchangeably or synonymously, which I would disagree with 100%. I mean, addiction is a bad problem. It's a disease that needs evaluation and treatment. Chronic pain is a completely separate entity that deserves evaluation and treatment. And the overlap between the two is probably the same as the overlap between addicts or people that are addicted that have diabetes, or people that are addicted that have schizophrenia, or people that are addicted that have no other health problems.
Yep.
So to unfairly correlate those two is a stigma that is very problematic.
Yes.
And there's no correlation.
Any more, Jen?
Yes, does pain management provide care for fibromyalgia?
In the continuum of what we do, that's one thing that we do offer treatment for, and that's a difficult diagnosis to make. I won't give you the specifics on it, but it's a real problem. It really speaks to kind of the core of the chronic pain issues that face us. And what I'm speaking to is the fact, how can you explain to someone who had a broken wrist, or let's say your brother had a broken wrist and it heals, and you have a broken wrist and it heals, and now you still have pain? I mean, days, weeks, months. And this is really the essence of what chronic pain is, whereby there's no outward sign of any active trauma or any active bleeding or bruising, but yet you still have pain. Fibromyalgia is one of those pain syndromes that there's nothing that you can show on a test or an MRI or blood work to a reasonable degree that would show that. But that's what chronic pain specialists do, is deal with issues like that. And fibromyalgia is one of those conditions.
So one of the other questions that we're moving up to the neck for a little bit. My neck has really been bothering me. Is it safe to use over-the-counter pain medications daily at 4-hour intervals to control pain? So I'll add a little bit to that. I think the question would be then, when is it safe for me to assume the diagnosis is something that I don't have to worry too much about and I can treat it symptomatically? I always worried a lot more about neck problems than I did back, that I was going to miss something. And not just ridiculous, the myelopathies. One of my really good friends, somebody was just telling me a month ago, can hardly walk now because he had some mild neck problems pinching on his spinal column, and so he couldn't walk. So what do you tell somebody like that? They need a diagnosis. They need to be seen, evaluation. They could have some medical kind of condition too before you start to do this. The same rationale for the neck as it would be for the back?
Pretty much. We alluded to this earlier, and I tried to allude to this earlier. I mean, these situations where your spinal cord can be irritated are very tricky. Right. Frequently that comes in the absence of pain. You don't have a lot of pain, but the symptoms, dizziness, arms being a little clumsy, maybe a headache or two, but you're falling. And again, there's many reasons one could fall, but this cervical spinal cord being irritated is one of those reasons. And that's something that we, as specialists, look for on a minutely basis. I mean, we're always cognizant of the fact that these issues exist. And really, the diagnosis is largely made on the basis of clinical assessment, but more importantly, structural. So an MRI gives us a really good picture of the spinal cord. And so that's how we'd handle that issue, essentially.
Well, and I think that the thing, and Dr. Kendall has said that, is the end may be that you have pain, but there's lots of different ways you can get to that pain. And we want to make sure we get the right diagnosis. Again, that just makes sense. And again, in my field of internal medicine, people came in with chest pain. Well, it could be due to a lot of things, and we need to make a good diagnosis before we can start to treat. And that doesn't mean you have to go to the doctor right away all the time.
And then, so back to the question, let me just finish the thought. If you're taking a painkiller every 4 hours, that to me seems a little excessive. I mean, most of the over-the-counter agents that are on the market are probably 3 times a day. If I'm doing that for weeks, again, this is my indication to myself that my pain is telling me that it's time for an evaluation and treatment. And I alluded to the fact that the oral anti-inflammatories, the ibuprofen and naproxen type medications, do carry a significant side effect profile. I mean, this can affect your esophagus, your stomach, your kidneys, your blood pressure to a significant degree.
Yeah, there's no free lunch on taking 1 aspirin a day. We admit 5 or 6 people a year that have gastrointestinal bleeding from that. So good point, well taken, especially if you have to do it chronically. So let's switch gears a little bit. So let's say you got a 25-year-old that feels, one of my kids, healthiest people in the world, nothing's ever going to happen to them. What's good advice we give to someone to prevent back trouble? Or does it make any difference? I'm going to get the arthritis anyhow. Is all the stretching make any difference, or Pilates or yoga or whatever everybody's doing?
Well, I can tell you, if you don't exercise, that's not a good thing. Typically speaking, weight control, aerobic capability, so exercising from a heart and lung perspective are critical. Specifically when it comes to back issues, prevention is worth 1,000 cures. I mean, if you're going to bend over and try and pick something up without using proper mechanics, and I guess the buzzword there is to use your legs, not your back. That can keep you out of some hot water, essentially in an acute one-time bending situation. I was alluding to the core strength. So the stronger the abdominal and the gluteal muscles are, and those are the muscles which really support the structures, or those are supporting tissues around the structure of the spine. The stronger, more capable in tone those muscles are, the less wear and tear on the spinal structures, that when they break down, you got a problem. And this leads to I'm referring to the arthritic and disc pain problems in the back. So core strength.
So a lot of people get in their own trainer or things like that. Not so much do you work with them, but does that make sense to you, that someone would, so that they know what exercises they ought to be doing?
No,
I think most of these trainers are pretty well trained as to what they're doing.
They are, and there's exceptions to everything. And obviously your feedback to your trainer would be, if I'm doing a particular move that's causing pain, I wouldn't do that. So some of the bending back stuff causes discomfort, whereas, some of the flexion work, like the crunches, wouldn't cause that type of reaction. And so from that perspective, yes, input is good. And then designing a plan that works for you is good. And that means, it doesn't take a lot of time. It's effective. It doesn't hurt you, and you're doing it with regularity. That's probably the best way to handle it.
And just because sometimes people are asked, any certain foods, does it make any difference? Has that got anything to do with any of your other lifestyle kinds of things besides the exercise and things you've talked about? Not that I'm aware of any, but any comments?
Not a correlation I'm aware of between, the simple sugars and back pain, for example, or fatty acids or triglycerides. But, generally speaking, I mean, the less weight you're carrying around, the less wear and tear on the spinal structures.
Okay. One of the things, and I think you've covered it, that I had a note was just the opioid crisis that we've talked about. Are you seeing as much problem? You talked about not treating that and things, but are people coming in that have been on opioids a lot, or is that changed, that we're making some progress of how we're treating people?
Well, it has changed. And back in about 2016 or so, there was some oversight at both the state and federal level that was making or precipitating both the provider as well as the patient to engage in assessments. And quite frankly, they made us account for essentially the medication we were prescribing, both from a pill count perspective as well as a regular assessment perspective. And this has helped to create the blur between, addiction, medication misuse, and pain management, because, the implication is, well, since you're using opioids, you're part of the problem. And I don't know if that was the fairest thing to do, but there was an opioid crisis in our country. People that suffer from addiction do use opioids to foster their addiction. And so we were roped in by that mechanism into having to be incredibly diligent on how specifically the opioid painkillers are prescribed. So there's oversight that has come out of the legislation that was secondary to the addiction problem, even though, again, we don't treat addiction, we treat pain problems. And so that's kind of where the overlap is. And so we just have to be very diligent, and we have to respect the newfound limits that some of the federal and state agencies have placed upon us, that if we, prescribe a large amount of pain medications, the level of oversight increases, in some cases quite dramatically. And I guess the take-home point is we're trying to be safe, not only for our patients, but for the population. So there is some rationale and some good that has come out of this. I think overall that, the amount of opioid that is now in the population has decreased a bit. And I think there's some sense and logic in that. And we find that, when you look at a pain problem, there's not a 1 pill or a 3 pill a day fix to these issues. And don't get me wrong, these are intense, debilitating pain problems. that I think, as you alluded to, and we've been kind of alluding to, these have to be treated with multiple modalities. Taking matters into your own hands, exercising, core strengthening after you get adequate relief from something that we do, combining that with physical therapy, in some cases, psychological therapy. You can imagine we've alluded to where the psychological tool can be incredible, using specialists like that to our advantage or to the patient's advantage. Having adequate surgical evaluations and so forth are really part of the continuum of care, and opioids are a small portion of that continuum, which can be beneficial when used safely and appropriately, which is what we are obligated to do for the safety of our patients.
And I think we haven't seen a change. Any comments about cannabis, or anybody ask you about that, or I guess everybody's rubbing this stuff on them. I don't know whether it works or not, but
so the long story short there is that there is some potential usefulness from a pain killing perspective of one of the components of cannabis, which is the CBD. Cannabidiol is the word for that. Unfortunately, there is no clear-cut preparation that has just the CBD in it, to my knowledge. And while they being the non-oversighted manufacturers of these chemicals, and what I'm saying is there's not FDA oversight over these supplements that are being prescribed right now, and I'll use the word supplement loosely. You can get the THC component, the cannabis component into it, which does not have an analgesic effect. In fact, it has central effects, things like disorientation and hallucinations and highs and lows and things along those lines. And so again, the line has been sufficiently blurred between CBD and THC to the point where here's your preparation. It could have some CBD, it could have some THC, it could have both, it could have neither. There is no controlled, designed, prescribed, manufactured preparation for CBD that's on the market, and there's no dose. And so, for example, I wouldn't tell you to go take aspirin and then you get a bottle of aspirin. Do you take one or you take 40? I mean, same thing with the CBD. Do you take, one squirt of the preparation, or do you put the whole bottle on? So, I mean, there needs to be more oversight and more generation of a process for that before we can use that in a medically appropriate way.
Yeah, and I personally think there may be something. It's a medicine, but we haven't done much research because it's been prohibited. And I just saw something today that we're talking we need to get more trials so that we can see if it works. And I think from a medical standpoint, we all agree on that.
Yeah, the cart is before the horse on this one. It's a potentially very useful modality that is getting kind of mixed up in the recreational side of things, and that's creating a problem for the medical use.
Yeah. Jen, any other questions?
No.
So last topic, COVID, from a standpoint, has that affected your practice? Or one of the concerns all of healthcare is having, people are putting off things because they're afraid to come in, they're going to catch COVID. Do you have protocols of what you do, or any just comments with your clinic and your practice of COVID in general?
Yes, I mean, we're committed to patient safety. And so obviously we've got distancing protocols, we've got facial covering protocols, personal protection protocols that we institute, in some cases testing. And so all these things in summary are designed to keep the patient as well as the members of our team safe. And so what has that created? As you can probably imagine, a little bit of oversight and burden from the perspective of we've got to create spaces that we didn't have to create before. Time intervals exist that didn't exist previously. It just creates a risk component that we have to address, and we do address. And so at the end of the day, there might be some delays and might be some additional testing or maneuvers that you have to go through. For example, like your ride or your loved one would have to wait in the car for you for a procedure. So things like that are just one of the things that we've instituted to keep our population safe.
Okay, thank you. Well, I don't think we have any other questions. I think we covered all of those. We appreciate all of you that have been online with us. If you do have any comments, we really do like to get feedback, how often we ought to do this, what other specialties you would be interested in talking to. So fill out that and send it back to us. Tom, really appreciate you being here.
Thanks.
It's been enjoyable as usual. I learned something. I learned as much just listening. So thanks a lot.
Thank
you. Again, thank you to everyone.
Thanks, everyone.